Welcome, Robyn Tamblyn.
Thank you.
You've said hospitals don't have the technical ability to undertake quality improvement. What's holding them back?
Well, I've personally sat on quality improvement, quality assurance committees for quite some time. And I think one of the challenges they have is and every single group who comes to present says the same thing, is they can't get the information. They need information. They want to know how well they're doing. A case in point was essentially the surgical team said, okay, we're having trouble with the operating room. You know, where patients are backing up, you know, we should be able to get many more people through per day. What's going on? So they undertook essentially, I would say, a quality initiative. They hired people to actually go and collect information on what was happening in sort of like a time motion sense of cases going through, what were the problems, and they spent maybe about a month on that. They hired a firm to help them do the analysis because there's no one in the hospital who knows how to do the analysis of, like, you know, what happens second 1, second 2, second 3, you know, let's make adjustments for the fact that the patients are different. So they were all said and done, they said, okay, we understand what the problem is now. The problem is that we actually haven't sequenced the anesthetist at the right time related to the time that the technician is available in the operating room. It's really a matter of managing the scheduling of those people at the right time, at the right place. So we understand the problem now, but we have no more money to actually solve the problem. So it's sort of, it happens again and again. And I think that stymies and prevents people from actually taking hold and saying, I think we have a problem, let's solve the problem.
So all these processes aren't being properly collected and tracked and annotated in any way. It's all seen as individual problems.
Yeah, it's all seen as individual, and I think the health professionals, by and large, get into this profession because they want to help people and care for people. They are not there to be statisticians or data collectors, and yet data is being collected increasingly electronically. And now it's a matter of saying, can we master that data, add to it, so that we can actually do quality improvement? And I think that's what we need. We need to know where we should strategically point our initiatives.
It's increasingly clear that electronic health information is key to delivering quality care. If you were going to try and make it happen, where would you start?
Well, there are a couple of strategies here, and there is a strategy that's being taken in this country. Just briefly comment on that, and that is that we need to build a complete Trans-Canada highway before we put a car on it. East to west, 4 lanes, you know, highly paved, et cetera. And in fact, even to this day, the Trans-Canada highway isn't 4 lanes all the way. So that's one way of approaching it, to say we want to have, you know, pristine foundation from beginning to end and have all the pieces and the parts. And probably by 2014, I'm not sure we'll still have professionals using electronic health records for patients. Another way of going about it is to say, look, let's do this very strategically. Let's go at where we know we have some problems, and let's get a rapid return on investment where we have some problems. And that's where I would go, because we have such huge problems, and there's such early wins. So I would go very definitely for low-hanging fruit. Many other countries have done the same thing, and they've said, listen, where we have a number of huge problems, but one place we have big problems is we have problems in the area of prescription drugs. And they often will start there because it's something that is not as difficult to do, and it actually gets you a really rapid return on investment. And why is that? It's because, well, a couple of things. One is that the cost of drugs is climbing so rapidly, it will outstrip, and has outstripped essentially the cost of medical physician services in our country, for example. Number 2 is that it's so easy to get it wrong. You know, we've had a number of very high-profile deaths in our countries just related to that issue. Couldn't read the illegible handwriting. Once it's computerized, then there will never be a mistake like 200 milligrams for 0.2 milligrams because, you know, it will essentially you will be able to say, oops, you can't do 0.2, you can't do 200 milligrams for a person like this. You know, it'll have the capacity to automatically alert to say, there are 2 planes about to crash together. Would you like to do something about that? So I think that's a great place to start, and many countries agree, and they've done just that.
If we took that small step, could we then build it into other uses for care, for improving care? I mean, that defines prescription drug use. Could you then use the same pieces of information to build into something more?
Absolutely. And in fact, we've started there. It's not that our group, our research group has started there. And we're starting in primary care because that's where all the drugs are prescribed. 80% of drugs are prescribed in primary care. What are they prescribed for? They're prescribed for chronic diseases. So we'll start there, and then they start adding stuff. Well, could you actually, I want a preventive, my prevention thing. I want to have, they should have their influenza vaccine here. I want to have it linked to my scheduling system so I can actually do call-ups for people who need to have preventive care. I want to have it linked to labs so I can actually review the lab results for all my diabetics and all my people with elevated cholesterol. And oh, by the way, can you give me my diabetic worksheet? And can you give me my asthma worksheet so that so pretty soon you start building incrementally to meet their needs. What will be in chronic disease is essentially a full electronic health record for them. That's where it's going. But it gives them incremental steps where with each step you have to give some value added that makes their day better. And what they've told us, oddly enough, is not I make more money, because you can't make more money, but it gives them a sense of professional autonomy that they've never had before. You've given them information that it takes them forever to get, and they feel much more in control of what's happening.
So you're integrating care one step at a time from the bottom instead of from above.
From the bottom, and you can see where they're going. They want us to tackle the big 5, hypertension, diabetes, heart disease, respiratory problems, cancer. Those are the big 5.
Thank you.